monitoring now. Before we start the basic hemodynamic monitoring, we have to revise certain nomenclatures. All cardiovascular pressures are expressed as millimeter of mercury except CVP, which sometimes we express as centimeter of water. In majority of the modern monitors, it is measured as a millimeter of mercury as well. But just for sake of conversion, 7.5 millimeter of mercury is equal to 10 centimeter of water. All the cardiovascular pressures are referenced to the heart, known as the phlebistostatic axis or phlebistostatic plane. All the cardiovascular pressures are above the ambient atmospheric pressure at the transducer is zeroed to the atmosphere. This is an invasive monitor which is transducer looks like. This is a fluid filled tubing. As you can see here is the fluid filled tubing. Then there is a three-way stopcock, and then there is a pressure transducer, flush system. This blue tail is a flush system. Then pressurized saline is connected to the system, and there is a cable to process the signals. What are the indication of arterial cannulation? When we want to measure the accurate BP, when the patient is especially in the shock, where the manual BP can be erroneous, continuous beat to beat monitoring is required, where we are giving vasoactive therapy, repeated arterial punctures needed because of the more than 4 blood samples if needed. Then it is mentioned that it is much better to place an arterial line rather than doing repeated puncture more than 4. Patient with gross edema, obesity, NIBP may be unreliable. Indirect assessment of intravascular volume status by method of pulse contour analysis, which we discuss in successive slides in the advanced hemodynamic monitoring. These are the different sites for arterial cannulation. Radial is the most common site, then femoral, then post-tibial and dorsalis pedis. Brachial should be avoided as it's an end artery, can cause no collateral, can cause problems. Radial is preferred, it is superficial, easily accessible, good collaterals from ulnar artery is present. So, how to do a modified Allen test? We ask patient to clench the fist, then then we occlude the ulnar and radial artery with both the thumbs. So, another person occludes the radial artery and ulnar artery. With this pressure on, we ask the patient to relax the hand. Within few seconds, 5 to 10 seconds, there should be a blank, like whenever he relax the hand, the blanching of palm and finger should happen, because we have already occluded both the arteries, radial and ulnar. Then one has to release the pressure from the ulnar artery. If the circle is patent, if the circulation is patent, then within 5 to 10 seconds that blanching will go away and hand become red. If the absence of flushing within stipulated time means that ulnar and radial circulation is inadequate, and at this point we should not cannulate of radial artery of that hand in same patient. These are the components of intra-arterial BP monitoring, where we have got a pressure bag, pressure transducer, which having automated flushes system, arterial line and saline filled non-compressible tubing. So what is transducer? A common question asked in exams viva many times. The transducer is equipment which converts one form of the energy to the another. So arterial pulse pressure is transmitted via a fluid filled column to a flexible diaphragm, which displays this diaphragm with each beat, and this converts arterial pressure wave into the electrical signal that is measured. So this transducer is converting the mechanical energy into the electrical energy which we are measuring, electrical signal. The pressure transducer relays its electrical signal via a cable to the microprocessor, where it is filtered, amplified, analyzed and displayed on a screen as a waveform pressure versus time. Leveling, how to level it, where to level it. The air fluid interface has to be aligned with the external reference point of the heart. This reference point is named as a phlebistostatic axis. It is the junction between mid-axillary line and fourth intercostal nipple sternum line. If level is too low, it will give you falsely high BP. If level is too high, it will give you falsely low BP. If your patient is in a semi-recumbent position, you can see the reference points is also going up. So take the phlebistostatic axis as a reference point in any position. What is zeroing? Zeroing is the exposing the air fluid interface to the atmospheric pressure and calibrating the pressure to zero. Zeroing establishes the interface level as the hydrostatic zero reference point. Level is unimportant during calibration. So at this point, if the patient is supine or a semi-recumbent, that hardly matters. You can do zeroing at any position. Line patency, how the system maintains the line patency. There is a flushing system. Usually we use 500 saline. Nowadays, hardly anybody is using heparin into this. Earlier we were using heparin, but because of the high incidence of HIT, people have stopped using the heparin. So 500 saline, which is pressurized to 300 millimeter of mercury. So we contain a bag with the pressure is there. Heparin may be added, optional. 1 to 2 ml per hour rate is of infusion. So it is called as a keep vein open or keep artery open is there. In children, this volume is lower, is less than 1 to 3 ml because it can be very high. How the arterial waveform looks like? It looks like this. The diastolic pressure is there, systolic pressure is there. There is a dicrotic notch which is happening because of the aortic valve closure, and there is a diastolic decay curve, and in between there is a mean pressure. How to differentiate between central and peripheral blood pressure? In a central blood pressure, anacrotic and dicrotic notches both are appear because aortic in the this is in the aortic pressure. Waveform is narrower in the peripheral thing. Systolic and pulse pressure increases. Both systolic pressure goes high and pulse pressure increases. Systolic pressure goes high because the resistance goes down, and upstroke become more steeper, and diastolic and mean arterial pressure decreases. So this is the comparison of different pressures at the aortic root, brachial artery, radial artery and femoral artery. Damping indicates the tendency of an oscillating system to return to its resting state. If you remember, there is a diaphragm in the transducer. Blood with each beat, the diaphragm is displacing. So it means it is oscillating against the fluid-filled column. Damping is tendency when it tries to come to the resting state. If there is any restriction to the transmission of blood pressure from the artery to the transducer, the displayed tracing would be smoothened out and sharp changes will not be displayed. A well damped system does not oscillate freely. Poorly damped system will oscillate freely. We check it with the flush test or square wave test by opening the valve of the continuous flush device such the flow system is acutely increased to 30 ml per hour, which was 1 to 3 ml per hour. Now it has been increased to 30 ml per hour. This generates an acute rise in the pressure within the system, producing the square wave on the monitor. What is happening? In the bag there is a pressure of 300 millimeter of mercury. In the artery the pressure is little less, maybe 120, 180, and at that pressure if we are infusing in system around 330 ml per hour, that will create a rise in the pressure, and that rise in the pressure is a square wave. It looks like a square wave because we have just pulled this valve open, and the moment you drop it, it goes down. With the valve closure, a sinusoidal pressure wave is of a given frequency and progressively decreasing amplitude is generated. A system with appropriate dynamic response characteristic will return to the baseline within 1 or 2 oscillation. So if it is not coming in the 1 or 2 oscillation, then it is a problem. We will see what it could be. So we look at the sharp rise with the flush test. The moment we switch on the flush test, there is a sharp rise. Here the sharp rise of the pressure, brief flat line, and then pressure goes down, and then there are 1 to 2 tracings, oscillations are there. So this is a optimally damped system where you can see 1 to 2 oscillation before returning to the baseline. Under damped system more than 2 oscillations, and over damped system less than 1 oscillation. You can see here it goes down, and next step is again the tracings are there. So this is under damped. What are the implication of this damping? If system is over damped, it will give you a low reading of the BP, systolic BP, high diastolic BP. As you can see here, in the over damped system, the systolic BP is less, diastolic BP is high. In under damped system, the systolic BP is high and diastolic BP is less. But the mean arterial pressure in both remains unchanged. Causes of damping, underdamping could be because of the compliant tube, long tubing, increased vascular resistance and tachycardia. Overdamping could be because there is an air bubble in the connecting tube in between the saline flush, and there could be blood clot, compliant tubing, catheter kinks, no fluid in the flush bag and low pressure in the flush bag. So how should we use this arterial pressure? A lot of useful pieces of information can be drawn from systolic arterial pressure, mean arterial pressure, diastolic arterial pressure and pulse pressure. So look at here, systolic pressure, it is always a reflection of LV after load. If after load is less, of course systolic pressure will be high. If after load is too high, systolic pressure may be the less. A low pulse pressure suggests that stroke volume is low, because this indicates the pulse pressure indicates the stroke volume. Diastolic arterial pressure is a reflection of vasomotor tone. A low diastolic arterial pressure is mainly due to a depressed arterial tone in the system. Mean arterial pressure is an important target for resuscitation of the patient with the shock. So look at here what is happening. Physiologically linked stroke volume, that is indicating the pulse pressure. Diastolic arterial pressure is a physiologically linked to the arterial tone. In same condition where systolic pressure is less, patient is a hypotensive patient, look at here, systolic pressure is 80, here also 80, but here the diastolic pressure is 30. It is because that this arterial tone and vascular tone has gone down, vasodilatation is there, it could be a septic patient, and here we require vasopressors. But look at this condition, the systolic pressure is 80 but diastolic pressure is very high. So here this pulse pressure is high, here the pulse pressure is low. So it indicates that there is a less in the stroke volume, less stroke volume has gone down. This high diastolic pressure indicates that patient is in a vasoconstricted state. It could be in a hypovolemic, could be in a cardiogenic patient where this reflex vasoconstriction is taking place just to compensate the mean arterial pressure. Coming to the CVP monitoring was used to assess the cardiac preload and assessing the intravascular volume status. So CVP is not so easy. CVP is a reflection of right atrial pressure which is used as an estimate of left ventricular and diastolic volume. Can you imagine putting CVP here at the right atrium? We are trying to measure the pressure here. Is it possible? Looks difficult. It's based on certain assumption. We will discuss that. CVP is determined by the interaction of cardiac function and venous return. So just imagine the cardiac function and venous return. When anything between them is having some problem, we cannot rely on the CVP. So CVP is a reflection of right atrial pressure which is used as an estimate of left ventricular and diastolic volume with these assumptions and these conditions. Look at, everything is normal. Left and ventricular and diastolic volume may reflect the left ventricular and diastolic pressure where the LV compliance is normal. Left atrial pressure is equal to the left ventricular and diastolic pressure in a normal mitral valve. Left atrial pressure is equivalent to the pulmonary artery occlusion pressure where the pulmonary artery catheter is lung zone 3. We will discuss that in successive slides. And there is a normal airway pressure. Pulmonary artery occlusion pressure is equivalent to pulmonary artery diastolic pressure in a patient where the pulmonary vascular resistance is normal, and CVP is equivalent to left atrial pressure where both the RV and LV are working as a parallel function, not in interdependence, which happens when the sepsis or any cardiac dysfunction happens. So just look at these conditions. They are mainly in a normal patient. When the patient is having some pathology, this correlation goes down. That is why we have stopped using CVP as a tool to assess the fluid responsiveness. Coming to the CVP waveforms, as you can see, this A wave, C wave, V wave is there, and X and Y descents are there. How they are formed? A wave is atrial contraction at the end diastolic, C wave is bulging of the tricuspid cusp, X descent is atrial relaxation which happens in the early systole, V wave is venous filling of the atria at the end systole, and Y descent is emptying of the atria into the ventricle. That's how these waveforms happen. If we combine it with the ECG, A wave occurs after the P wave in the PR interval, C wave occurs at the end of QRS complex, V wave occurs after the T wave. This is a classical CVP tracing of tricuspid regurgitation. As you can see here, the V wave is higher than the C wave. They are called as cannonball CVP. This is the tricuspid stenosis CVP tracing. This is tracing of the cardiac tamponade. As you can see, the attenuated Y descent is there. So when to measure CVP? A peak of the A wave coincides with the point of maximal filling of the right ventricle. Therefore, this is the value which should be used to measure as a right ventricular end diastolic pressure. Machine just average out the measurement because in the monitor when you see it just averages out. It should be measured at the end expiration. We will discuss why at end expiration is important. If you look at the spontaneously breathing patient, what happens here? Because in a spontaneously breathing patient, during the inspiration the intrathoracic pressure is negative, whereas during the expiration gradually pressure goes up. So at the end of the expiration the CVP is highest. In a ventilated patient where the positive pressure ventilation is going on, so intrathoracic pressure rises during the inspiration. At that point of time, at the end expiration, the CVP is the lowest because the pressure reflection. We will discuss this. So how to locate end inspiration? With spontaneously breathing patient, locate waveform just before the pressure decline on the inhalation. And in mechanically ventilated patient, locate waveform just before the pressure rises with the inhalation. During spontaneous ventilation, what is happening? There is a decreased pleural and pericardial pressure in the inspiration and there is a decreased transmission to the right atrium. This causes a decrease in the measured CVP, but transpleural pressure may actually increase at this point of time. In mechanically ventilation patients, mechanical ventilation causes the opposite effect during the forced inspiratory breath. Pleural and pericardial pressure are almost equal to the atmospheric pressure at the end of expiration. Why? Because at the end of expiration, the alveolar pressure is equals to the atmospheric pressure. There is no gaseous exchange at the end of the expiration. Inspiration has not started and all the gas which is on the air which is filled in the lungs is gone out. Excess. So at the end of inspiration, both the pressures are equal. Atmospheric pressure is equal in the pleural and pericardial pressure. This is true with both spontaneously breathing patient as well as ventilated patient because the physiology is the same. This point in the time provides the best estimate for the transmural pressure and the cardiac preload. So CVP is always measured in the end expiration. Elevated CVP could be because of the hypervolemia, pneumothorax, hemothorax, intra-abdominal hypertension, pericardial tamponade, mechanical ventilation with the PEEP. So coming, how useful is the CVP? This paper was published few years back, almost in 2015, named as a FINICE trial by Ciccone et al., where they have checked how people are using. So in this survey, in this study, they found out that close to 2/3 of the people, maybe 3/4 of the people are using static variables for fluid challenge and they are still using CVP. Whereas as you can see here, no, almost 44% of the doctors are not using at this point of time in 2015, they were not using any variable to predict the fluid responsiveness. Another studies by different studies where they have shown that these are the CVP with the responders to the fluid challenge and non-responders. As you can see, almost equal number of the people where the CVP has gone up with the fluid challenge and where there is a no response in the CVP. So it is difficult to assess whether CVP is having some effect on the fluid responsiveness or not. So another article published in 2008 in Chest by Paul Emerick, does central venous pressure predict fluid responsiveness? In this systemic review of the literature, they included 27 studies around 800 patients, and they said that absolute CVP value targets are useless unless they are extremely low. CVP is an important variable as it is key determinant of the venous return and the organ perfusion pressure. CVP is best interpreted when looking at the changes CVP and concomitant changes in cardiac function. So it is helpful to diagnose right ventricular dysfunction, helpful to target the optimal mean arterial pressure, and not helpful to predict fluid responsiveness. So big question, should we measure the central venous pressure to guide fluid management, is published by DeBaker and JL Vasa in 2018. So they have discussed very beautifully about the pros and cons. Measuring the CVP, it is easy to measure, minimal apparatus is needed and it is cheap. But con is there could be error in measurement, influence changes because with the mechanical ventilation, and it can influenced by the abdominal pressure as well. CVP for fluid responsiveness, the predicted value of extreme CVP value, if it is less than 6 to 8 millimeter of mercury, or if it is higher than 12 to 15, is satisfactory. So what they have said, you can take a range. If it is less than 8, you can give the fluid. If it is higher than 12 to 15, you should not give the fluid to these patients. The cone is the predictive value of fluid responsiveness is lower with the CVP than the dynamic indices. So we should better rely on the dynamic indices rather than CVP. CVP as a safety valve during fluid challenge, given CVP value can be used as a safety valve. But against to this argument is this safety valve value should be individually determined, as there is no predefined safe limit of the CVP. So we have to individualize the CVP level. CVP as a target value in circulatory failure, this population based approach may be used to ensure that the majority of the patient achieve a satisfactory hemodynamic goal. But against argument is in circulatory failure, a significant number of patients may be submitted to the excessive fluid administration if we are having a predefined level, whereas other patients may require additional fluid administration. So in patients without indices of hypoperfusion, this approach is not recommended, as it could lead into unnecessary fluid administration. Influence of mechanical ventilation, again CVP may fail to reflect intravascular pressure during the mechanical ventilation. CVP can be used to evaluate the response to the fluid. The against is the increase in CVP indicates the increase in preload but does not indicate the response to fluid. In fluid responders, the increase in CVP should be minimal with a large increase in the cardiac output, while non-responders, the increase of CVP is larger. So again, is not of much use. CVP value provides important information about the cardiocirculatory status of the patient and should not be abandoned. Use of CVP to guide fluid resuscitation has many limitations, but we believe it is wiser to understand and take into account of these limitations rather than to discard CVP completely. So what happens? The effect of PEEP. CVP and pulmonary artery occlusion pressure is generally higher with the PEEP. CVP is indicating the intravascular right atrial pressure. So solution, do not subtract arbitrary value. Many times many people say they just subtract the PEEP from the CVP, you will get a right CVP. It should not be done. Do not disconnect the ventilator, because if you feel that you will mitigate the effect of the PEEP, just disconnect the ventilator. It may cause much more problem than the benefit. Patient may de-recruit at that time. Check CVP trend, not rely on a single value, and guide therapy with a fluid challenge. PA catheter, as you all know, PA catheter is having different parts. This is a balloon port which is having a syringe fixed to it. Syringe is having 1.5 ml of the volume. This is a thermistor, this is a CV port, and this is the PA port. PA port is opening somewhere here and CV port is opening somewhere here. So PA port is opening proximal to this balloon and CV port is opening distal to the balloon. Distal means if we talk about from the pulmonary artery side. But if we talk about this area from here, of course this is the distalmost part. So PA port is the distalmost part. This is the tracing of the different areas, different chambers. So in right atrium you will find tracing like this. In right ventricular, the tracing is like this, and the moment we enter into pulmonary artery, the tracing goes up because the diastolic is high, diastolic pressure, and then we do occlusion. This is how. So how we introduce? Up to right atrium we put it up blindly, and after right atrium we inflate the balloon and it is guided by the balloon. because in the flow, in the blood flow, the balloon is having air, it floats. That's why it is called as a float. Many times we say that have you floated the swan? So that's how it floated, and with the flow it goes forward and we push it accordingly. So there are three lung zones. There could be a zone 1, zone 2 and zone 3. If you look at the zone 1, PA can go anywhere out of these three zones, but you have to identify the correct zone because the interpretation will be wrong if it goes to a wrong zone. Where it should go, in which zone it should go? Zone 3. So what is the problem with the zone 1? Look at here. Here what is happening? The pulmonary artery pressure is less than the alveolar pressure, and it is pulmonary alveolar pressure is highest here because this is having the best air supply in the zone 1, and it is so it does not, whatever we measure, if we do a balloon here and inflate the balloon, it will measure the alveolar pressure rather than measuring anything. If we talk about the zone 2, what is happening here? Pulmonary artery pressure is higher than the alveolar pressure and the pulmonary vein pressure. So what is happening? Whatever we are measuring is not a true reflection because this is not being occluded fully. The flow is not unrestricted here. Here you can see the alveolar pressure is the lowest. So if I am inflating balloon somewhere here, it is totally occluding the this pulmonary capillary, and whatever I am measuring from the distal port is being measured from the reflection of this area. So pulmonary artery diastolic pressure is always higher than pulmonary capillary wedge pressure. Arterial pattern of the waveform we have to see. Catheter tip below level of the sternum in the lateral X-ray. Free aspiration of the blood from the lumen with the balloon inflated should be there. And PO2 of the blood aspirated from PA with the balloon inflated should be equal to the PaO2 of the patient. So that's how it is being done. We inflate the balloon somewhere here. In this capillary, there is no progressive flow from the pulmonary artery. So whatever we are taking here is the static blood column, and this static blood column is filled with the blood which is going into the left atrium. So we are taking as oxygenated blood. That's why if we take the sample from this tip, it will, the PA will be almost, the PaO2 will be all same as the taken from the arterial line. The occlusion tracings are similar to the CVP tracing. Pulmonary artery occlusion pressure is a reflection of left atrial pressure. There is no identifiable C wave here, and high mean pressure is there, 10 to 12 sometimes could be there. Indication of pulmonary artery catheter, high risk cardiac surgery. In non-cardiac surgery patients, in a high risk cardiac cases, we can put it to measure mixed venous saturation, measure right and left heart pressures, and optimize the vasoactive, inotropic and fluid therapy. These are the normal pressures. Right atrium, the range is from 0 to 6, mean is 3. Right ventricular, the systolic is 17 to 30 and diastolic is 0 to 6. In pulmonary artery, systolic is 15 to 30, diastolic is 5 to 13 and mean is 10 to 18, and pulmonary artery wedge pressure is 2 to 12. These are the limitation of pulmonary artery catheter. Condition where the pulmonary artery wedge pressure can be higher than the left ventricular and diastolic pressure in the presence of mitral stenosis, mitral insufficiency, left atrial myxoma, pulmonary embolus, COPD, positive pressure ventilation and the high PEEP. Conditions where the pulmonary artery wedge pressure will be less than the left ventricular and diastolic pressure, where the decreased LV compliance is there in a patient who are having ischemia and hypertrophy of heart. The high LVED, left ventricular and diastolic pressure is more than 25, then the pulmonary artery wedge pressure can be less, and in the patient who are having aortic insufficiency. These could be the complication of putting a PA catheter. The procedure related could be hematoma, hemothorax, failed procedure, arterial puncture and arrhythmia. The pulmonary artery catheter related complication can be knotting of the pulmonary artery catheter, failure to reach in the correct position, arrhythmias, balloon rupture and pulmonary venous rupture. So pulmonary artery catheter, what are the reasons for the decline of PAC? So main reasons are large RCT showing neutral effect of the PAC, emergence of other advanced hemodynamic monitoring systems like pulse contour analysis, Then development of bedside echocardiography in ICU and emergence of fluid responsive concept that and the functional hemodynamic monitoring approach. So this is again a summary of pulmonary artery catheter. As you can see here, the main indication, if we are talk about the pulmonary wedge, this is the pulse wave analysis, non-calibrated pulse wave analysis calibrated with thermodilution, transpulmonary thermodilution, and pulmonary artery catheter. As you can see here, they all are comparable except in the severely ill patient with marked left or right cardiac dysfunction. These things can go wrong, then we need a pulmonary artery catheter. Although it is obvious that pulmonary artery catheter should not be used in most critically ill patient, PAC is still indicated in some patients with circulatory and respiratory failure, especially when the associated with pulmonary hypertension or left heart dysfunction. Thank you.